Very good morning, everyone. I am Dr. Rahul Agarwal. I welcome you back. And today we will discuss about the emetics and the anti-emetics. Emetics means emetics is a simple term. Emesis, it means the vomiting. So when there are certain circumstances where the vomiting is required, if you ingest, if you take some harmful substances, then emesis is required to remove that. But in certain situations only, and the anti-emetics means to stop the vomiting. So we have the drugs for both the MSs also and for the to stopping the vomiting also. So with this background, uh, we will now first see the MSs. MSs means the vomiting. So it is a protective mechanism. This MSs is required to eliminate the harmful substances when ingested from the stomach and the duodenum. But remember one thing, MSs will work only when the substances has not been absorbed from your stomach, from your intestine. If it is once absorbed, it cannot be removed out through MSS. Simple. So this is the two important areas, CTZ and NTS. We'll see that areas. It will be more clear when we go later on. CTZ is the chemoreceptor trigger zone, and NTS is the nucleus tractor solitarius. These are the important areas from where the impulses come to that area, and that impulses travel to the vomiting center, which is present in the medulla. The impulses from the GIT, throat, and other viscera, like suppose if you have if you have pain in the stomach, then impulse goes to the CTZ or NTS, then it goes to the vomiting center, and then the vomiting occurs. So CTZ is the NTS is the nuclear tractor solitarius, and chemoreceptor trigger zone is the CTZ. Okay. So pathophysiology is very important. First, we will understand the pathophysiology of MSS. We have the vomiting center, which is situated in the medulla of the brain. And in the medulla, there are certain receptors. M is the muscarinic, 5-HT3 is the serotonin, D2 dopamine, H1 histaminic, and NK1 is the neurokinin 1 receptor. When these receptors get stimulated, the vomiting center will stimulate. Vomiting center, when get stimulated, it will cause the for emesis, means vomiting. CTZ, we all know that CTZ lies outside the blood-brain barrier. When this chemoreceptor trigger zone get stimulated, the receptors which are present in the CTZ area related to the vomiting are the D2, 5-HT3, NK1, and CB1. When this will stimulate the vomiting center. And cancer chemotherapy, when we give the cancer chemotherapy or when we give the opioids, it will stimulate the chemoreceptor trigger zone. Uh, and then it can further stimulate the vomiting center. One important thing, pharynx and the GIT, like in the GI system, there is a receptor only 5-HT3. This you have to take it clear. Please remember the receptors which are present in the pharynx and the GIT. It's a 5-HT3 receptor. And this pharynx and GIT can directly stimulate the vomiting center, or it can stimulate the vomiting center through this CTZ. That means for the MSs or for the anti-MSs from the GIT or the pharynx, it is not required to activate uh, it is not required to cross the blood-brain barrier. Outside the blood-brain barrier also, it can stimulate the CTs. The vomiting center can be stimulated. So, like in chemo and radiotherapy, when you give or gastroenteritis in the infection, there is vomiting. How this vomiting occurs? Because of this mechanism, it stimulates the pharynx and the GIT. Then it can stimulate directly vomiting center, or it can stimulate uh, through CTZ, which is present outside the blood-brain barrier. I think I'm clear. Another important thing regarding the motion sickness. Motion sickness is the sickness when you travel through bus or through train or through anything, when you travel, when it gets stimulated, the vomiting center gets stimulated. And the two receptors which are present for the motion sickness is the muscarinic and the histaminic, not the 5-HT3. Please mark it. 5-HT3 is not present for the motion sickness. For the muscarinic and H1 receptor. So when you move your um, vestibular nuclei will get activated, and will activate the muscarinic and H1 receptor, and vomiting center will get stimulated. Cerebral cortex. Often you have seen when you smell, sight, or thought something, then also the vomiting occurs. This is again, this is called anticipatory emesis and stimulates the vomiting center. So when the vomiting center, all of these things are stimulating the vomiting center, and when the vomiting center gets stimulated, the emesis will occur. So this is the pathophysiology of the emesis. This is very important. This chart is very important because we will activate these when we want emesis. We will activate these centers, and when we want anti-emetic, when we don't want vomiting, then we will uh, deactivate these receptors. Okay, so this is our target of action also. Emetics, we can classify the emetics according to the site of action, whether it is centrally acting or whether it is peripherally acting. Centrally acting means it is acting on the brain. There is, I have shown you in the previous slide, there is a vomiting center which is present in the medulla, which get activated, causing the emesis. According to the site of action, centrally acting, apomorphine and morphine. Apomorphine is a congener of morphine only. So centrally acting, but it is not very safe because morphine itself is depressant in the respiratory center. So we don't use very much this apomorphine and morphine. In the peripherally acting, there is a mustard, potassium titrate, and hypertonic sodium chloride. There is one more thing which acts on both the central as well as peripheral. So both the centrally and the peripherally acting is Ipecac aquana, and that we used very frequently. Okay, so this is the to do the emesis part. Okay, now where all the emetics are contraindicated. Emesis is causing the vomiting. Suppose the poisoning is due to the alkali or the acid. Corrosive, if it is a poisoning due to corrosive chemical, then when emesis is occurring, it will come to the esophagus part, and it can burn the esophagus. So that's why emetics are contraindicated in corrosive poisoning. Emetics contraindicated in CNS stimulant drug poisoning also, because it can cause the seizures activity. Kerosene poisoning because of the aspiration. When there is when you are stopping, the it can cause the aspiration. And unconscious patient, again, the aspiration can be problem. If you are doing the MSS, uh, if you are promoting the things going to the esophagus, it can regurgitate into the trachea also. Morphine or phenothiazine poisoning, because it can again uh, increase the activity of morphine. So emetics are contraindicated in these conditions. Now coming to the pathophysiology of emesis. Why we are seeing again? Because we have the target for the anti-emetic drug. First, we can target this D2 5-HT3 NK1 CB1. It is outside the blood-brain barrier. We can target the 5-HT3 receptors. Yes, we have the 5-HT3 receptors antagonist drugs. We can target the muscarinic and H1, and we can target the again this also. So basically, what the receptors we have, we have the anticholinergic. When we give the anticholinergic, then also vomiting can be reduced. When you give the 5-HT3 antagonist, yeah, or it is also known as serotonin antagonist, then also antiemetic activity can be achieved. When you give the H1 antihistaminics, so remember that it is a H1 antihistaminic, then also antiemetic can be achieved. When you give the NK1, NK1 is the neurokinin 1 receptor, then also antiemesis can be achieved. So with this background, we will see now the classification of antiemetics. So we have we have seen that when we are giving the anticholinergic, it is blocking the muscarinic receptor, cholinergic receptor. Then antiemetic activity can be achieved. Hyoscine or dicyclomine, the basic drug, this one. H1 antihistaminics, promethazine, diphenhydramine, cyclizine, meclizine, cinnarizine. H1 antihistaminics, basically H1 antihistaminics has the anti-allergic role, but it can also be useful in the antiemetics. It is blocking the H1 receptor. Neuroleptics, D2 blockers, these neuroleptics we will cover in the antipsychotic parts. But here, the neuroleptics D2, because there is a D2 receptor, chlorpromazine, prochlorperazine, haloperidol. But these D2 blockers which they have written, which I have written, These D2 blockers, they act in the low dose. At the high dose, they are acting as a antipsychotic drugs. Okay. Then another agent, prokinetic agent. Prokinetic agent, metoclopramide, domperidone. These are also the D2 blockers. Again, the D2, but they block some activity more than the D2 blockers. So that's why not written in the neuroleptics. So metoclopramide, domperidone, cisapride, mozapride. We'll see that. Then another was the 5-HT3 receptor. 5-HT3 receptor we can inhibit, and that is all the drug having with the cetron, ondansetron, granisetron, dalocetron, pelanositron. Then there are some other antiemetics also. Corticosteroid also have proven the role as an antiemetic. And even when the MSS is not controlled with the ondansetron, we used to combine with the ondansetron with the corticosteroid. Benzodiazepines and cannabinoids are also having the antiemetic role. And one very important, the new addition NK1 receptor antagonist. And in the NK1 receptor antagonist, we have the aprepitant and fosaprepitant. That is the NK1 receptor antagonist that is very helpful in delayed nausea and vomiting. Happens because of the cancer chemotherapy. Okay. So this is the classification. This was the classification of antiemetic drug. So next, coming to the some individual drugs, anticholinergic, hyoscine or scopolamine. In the anticholinergic, we have the hyoscine and scopolamine, and it is uh, uh, available in the oral or IM, but it is also available in the transdermal patch. This you have to remember. We have the transdermal patch which applied behind the pinna. Anticholinergic scopolamine transdermal patch is there, which is a 1.5 milligram applied behind the pinna, and that deliver the drug over 3 days. So apply the patch for once, and that will deliver the drug over the 3 days. And can suppress the motion sickness while producing only mild side effect. So side effect also will be very mild. The second drug is doxylamine, which is an H1 antihistaminic. But doxylamine is the proven FDA approved drug for the morning sickness which is occur in pregnant women. The doxylamine is available with the combination of pyridoxine. See this one, doxylamine plus pyridoxine is written. Doxylamine is available with the combination of pyridoxine, which is a vitamin B6. So it is a FDA-approved drug for the morning sickness. Okay. So anticholinergic, antihistaminic, we have finished. This is very important. What we have written, all drugs for motion sickness are more effective when taken half to 1 hour before commencing journey. The drugs for the motion sickness will be only effective when you are giving the drug before the journey, not after the journey. So you have to give the drug before the journey only. No role in the treatment once the vomiting start. So once the vomiting start, then you have to give another drug. But for the motion sickness, we have the two receptor which was there in the motion sickness. You remember? One was the H1 and one was the cholinergic. So only these two drugs will be beneficial in the motion sickness, not the 5-HT3 antagonist drugs. Okay. Okay. Neuroleptics. I have told you neuroleptics is a D2 blocker that block the D2 receptor, but that neuroleptics at the it will behave as an antipsychotic, and at the lower dose it will behave as an antiemetics. So not very commonly used, should not be administered until the cause of vomiting has been diagnosed, because you are giving the neuroleptics. By blocking the D2 receptor, it can have the many adverse effects. What the adverse effect we can see with the D2 blocking? If we go to the CNS, when there is a less dopamine, there will be the extrapyramidal symptoms can be seen. So not very safe drug. So we don't use neuroleptics as antiemetics. Prokinetic drugs, these are important, and we'll cover the prokinetic in a different lecture, different video. Prokinetic drugs are also that they promote the GI transit and speed the gastric emptying. In the prokinetic, we have the metoclopramide, domperidone, and cisapride. But metoclopramide, what's the difference between the metoclopramide? Which is better antiemetic, metoclopramide or domperidone? This is another question. Remember one mnemonic I want to give: M for Ma, M for metoclopramide. Ma can go anywhere. Like that only, the metoclopramide can cross the blood-brain barrier also. Metoclopramide can cross the blood-brain barrier also. And when it crosses the blood-brain barrier, then After crossing the blood-brain barrier, it blocks the D2 receptor inside the brain also. So it will have the adverse effect, like the extrapyramidal side effect I was talking about. Extrapyramidal, one of the extrapyramidal side effect is Parkinsonian-like feature. As CTZ is outside the blood-brain barrier, both have anti-emetic effects. As metoclopramide crosses the blood-brain barrier, it has adverse effect like extrapyramidal side effect. Okay, clear? M for metoclopramide, M for MA. So metoclopramide can cross the blood-brain barrier also. So domperidone will be much more safer than metoclopramide in this regard, because domperidone will not cross the blood-brain. And one thing you might be knowing, you have the combination of PAN-D, like you have the combination of the drugs with the domperidone. You have not seen the combination with the metoclopramide, because metoclopramide is not safe. It can cross the blood-brain barrier. But domperidone is safe. PAN-D is pantoprazole and domperidone. Okay. So domperidone is well tolerated. Now, 5-HT3 receptor antagonist. This is a very important drug for the anti-MSS part. 5-HT3 receptor, serotonin, different. We have the different serotonin receptor, 5-HT1, 2, 3, 4, 5. So 5-HT3 receptor here I am talking about the 5-HT3 receptor antagonist. All the drugs ending with the cetron, ondansetron, granisetron, dalanositron, cetron. Ondansetron was the uh, first drug which was approved, and uh, after that, the granisetron, dalanositron, they came into the market. Affects both central and peripheral sites. Competitively blocks the 5-HT3 receptors. So this, go to the previous diagram, which I was flowchart I showed you. So 5-HT3 receptors was present inside the brain also, was present outside the brain also. Okay? So it can located on the nucleus of tractus solitarius, CTZ, or in the GIT also. So if you are having the gastrointestinal infection, what type, what yeah, or what at what receptor will you want to act? Your drug you want to act. So at 5-HT3 receptor was present in the GIT, so you have to give the 5-HT3 antagonist only. Okay. Something about the endocentrate pharmacokinetic metabolized by CIPs and is eliminated with well absorbed orally. Half-life is 3 to 5 hours, but then also we can give the only the once a day. Why? Because of duration of binding with the receptor. It has longer duration of binding with the receptor. That's why it is used only once a day. Half-life is less, but then also we can use once a day. So potent anti-emetic among the all the cetron, so the palanositron is the most potent. P for palanositron, P for potent, and is the longest half-life of palanositron is 40 hours. And one I have introduced one patch also. The transdermal patch is available of the cetron, and only granisetron transdermal patch is available. No other transdermal patch of cetron 5-HT3 antagonist is available. Okay. And main use of 5-HT3 antagonist is it's a drug of choice for chemotherapy and radiation-induced vomiting. So it can be given before chemotherapy also and after chemotherapy also. IV infusion given 30 minutes before the chemotherapy. And if you want to give the after the chemotherapy, you have to divide the dose accordingly. Okay. It's a very excellent safety profile is there. Very less adverse effect. Headache and constipation, just only the common side effect. Hypotension, bradycardia can be seen when given with the IV injection. Not very common side effect. Not very commonly the side effects are seen. Okay. This you have, I think you know the ondansetron MD. What is MD in this? MD is mouth dissolving. Very commonly it is sold. Ondem 4 mg or 8 mg tablet is there. NK1 receptor antagonist. This is the new receptor NK1. That is also known as NK. Full form of NK is neurokinin, and the substance P. Neurokinin is also known as substance P. This receptor is located on the CTZ. And where is CTZ? CTZ is outside the blood-brain barrier. Very good. CTZ is outside the blood-brain barrier. So when you giving the things orally, if the drug is not going inside the blood-brain barrier, inside the brain also, then also it can be get activated. We have the aprepitant oral and the phosphaprepitant. The phos group is added, that is converted into IV. The aprepitant and phosphaprepitant. And that is basically, but NK1 receptor antagonist basically used for the delayed vomiting, which occurs mainly for the platinum group of mm, uh, cancer chemotherapy. Platinum group, cisplatin, carboplatin, oxoplatin. Cisplatin most notorious for the vomiting. So for delayed vomiting after 2 days due to cisplatin, an adverse effect after NK1 receptor adverse effect is fatigue, dizziness, and diarrhea are the important adverse effect. So NK1 receptor antagonist basically used for the delayed vomiting. Okay. Now, can you please answer this question? A physician has prescribed the tablet ondansetron for prophylaxis of motion sickness. For the motion sickness, ondansetron is prescribed. Even though ondansetron is a potent antiemetic, ondansetron is a very potent antiemetic. It is used for the cancer-induced nausea, vomiting, chemotherapy, or radiotherapy induced nausea, but it does not produce any effect here in this patient. Can you explain why? Yes, very good. Vestibular nuclei has only two receptors. In the previous slide, we have seen that when in the motions, for the motion sickness, the vestibular nuclei is responsible, and the vestibular nuclei has only two receptors. One is the muscarinic and one is the H1 histaminic. If you are targeting these two receptors, then only the vomiting can be controlled in the motion sickness. But ondansetron is a 5-HT3 receptor antagonist. Ondansetron is a 5-HT3 receptor antagonist. So that's why vomiting cannot be controlled here. Okay, that was the thing. And coming to the finally for the some of the MCQs for you. So please answer the MCQs. Emitting center is situated in which region of the brain? Cerebrum, cerebellum, medulla oblongata, hypothalamus. So what is the answer? Yes, medulla oblongata. We have seen in the chart, the flow chart with what I have depicted. The flow chart is very important for you. Flow chart, you will not find your flow chart like this anywhere. So please go through this flow chart. This is very important. This is covering the major aspect. An example of 5-HT3 antagonist, metoclopramide, ondansetron, domperidone, and apomorphine. Please answer. Yes, ondansetron. Metoclopramide is D2 blocker. Dopamine in the it's a D2 blocker. Domperidone is a D2 blocker. Again, metoclopramide and domperidone are both the D2 blockers. I've covered in the prokinetic agent. Okay, so we'll see how these are acting as a prokinetic agent in the next video. So, but metoclopramide and domperidone. Among the metoclopramide domperidone, which one is safe? Domperidone. Domperidone is safe. Apomorphine. Apomorphine for the vomiting, for the inducing the vomiting. Okay. Thank you. Thank you very much. Another one more question. Which drug is used for the motion sickness? Domperidone, aprepitant, lorazepam, cyclizine. Which one? Motion sickness? The answer is cyclizine. In the motion sickness, we have the two receptor for the motion sickness. One was the serotonin and one was the serotonin 5-HT3 and one was the H1. And cyclizine is an H1 receptor antagonist. Domperidone is again D2 blocker. Aprepitant is a NK1 and lorazepam is a benzodiazepine. So the answer is cyclizine. Thank you very much. Thank you for paying attention.